Good morning, good afternoon, and good evening, everyone, wherever you are, and welcome to yet another webinar co-organized by A&T Neuro Education. My name is Farnoosh Safavi. I'm the head of education department, and today I'm honored to be hosting the webinar on language tasks in stimulation mapping. This webinar will be presented by Dr. Ann-Katrin Ohlerth, a good friend of mine, who is a clinical neurolinguist currently located as a postdoctoral researcher at the Max Planck Institute for Psycholinguistics in Nijmegen, the Netherlands. With a background in linguistics and further education in neuroscience and its applications in clinic, she dedicated her PhD, completed in 2022, to improving the depth of linguistically valid tests during peri-operative mapping of language. By carefully designing and tailoring language tests to the individuum, she works on the individual localization of language production, both on the cortex and in subcortical networks, in order to preserve the quality of patients' lives undergoing brain tumor surgeries. So after this interesting presentation, we'll watch a relevant demo prepared by A&T Neuro application team. And in the course of the presentation, you will also have the option to type your questions, as always. And you will also see some poll questions which require your active participation in order to keep the session more engaging and interactive. So, Ann-Katrin, once again, we do appreciate you accepting our invitation in this webinar today. And without further ado, we are very much looking forward to your presentation. Thank you.
Well, thank you as well for the kind introduction. And yeah, welcome to everybody. I hope you can see my full screen. It just switched back to seeing me, but I think now we should be on full screen again. Perfect. So you can also read my title that was already read out to you, language tasks that we're using in simulation mapping, and particularly how we might want to extend the mapping protocol. Now, you've heard quite a bit about my background already. So right now, I would like to have you participate in the first poll by telling me a bit more about your background. Is it a scientific one? Are you a clinician, a technician, or have a different background? This might help me a little bit to tailor some parts of the presentation.
So the poll is ongoing.
Yes. I will give you a few more, a bit more to answer before I continue to the actual content.
So let's close the poll, and I'd like to share the results. It seems that the majority, 45%, have other skills other than technician, clinician, and neuroscientist. After that, 27% neuroscientist or scientist, 18% technician, and 9% clinician. Is that what you expected?
Quite a varied background, so that's great to hear, but which also will mean that I'm not jumping over any topics. But yeah, I will stay with most of it. And yeah, we're expecting questions after the talk. But yeah, let's dive into it. Since some of you come maybe from a background that's not clinical, first of all, I would like to answer the question about why we're doing stimulation mapping. One of the main reasons, and where I come from or where it's most applied, is for finding functional hubs in the brain. So we know quite a bit about the brain, especially about the healthy brain, and which areas host which functions. And those functional boundaries, so where exactly the function begins or ends, we know a bit about it, but it already greatly varies in the healthy individual, and even more so in the presence of a tumor. for instance, a lesion, for instance, a brain tumor, meaning we have an entity in the brain that doesn't belong there and that's causing the function that we kind of can locate in the brain, causes it to migrate to even less predictable areas. So both neuroscientifically and clinically relevant is then to delineate those functional boundaries in the individual, both on the cortex and on the subcortex. This will enable us, for instance, to then execute a safe surgery on only the tumor tissue while avoiding the function. And functions we can delineate by now in the brain with stimulation, and I'll come to that in a second, are motor function, arithmetic, so calculation function, facial recognition, and today's topic, language. And how do we do this delineation? This can be done through imaging. One of the techniques known to people from all kinds of backgrounds is usually fMRI, so putting people in the scanner and more or less indirectly measuring which areas receive blood flow and oxygen during execution of a task, or stimulation mapping. And here's how that works. We are using the assumption that when we're directing stimulation to a certain area in the cortex, we can temporarily disrupt the normal neural activity that goes on in that concise area. So normally it's working fine on its own, but directing stimulation here disrupt what it's usually doing. And now if we couple this, the stimulation with the patient or participant taking out a task, it lets us probe the region for its functionality. So if this is the area in question that we're investigating, we first start by having a baseline of the task, meaning we show our task without stimulation to the patient or participant to know that they can perform the task normally. So to end up with a good item list. So for instance, we're showing it here, a picture of a cup or a book. And only once we have a good stimulus list, we move on to the actual stimulation mapping. Now we show the pictures again, but now simultaneous to this, we're stimulating a part of the brain. If then, as an outcome, the patient or participant cannot name that picture anymore, so cannot perform, we seem to have found a positive, so an involved area that was possible to disrupt. Vice versa, we might stimulate at a different point, show a different picture. The participant is fine, can name the picture, so we're seeing no error, therefore a negative area, so a non-involved area. When we now go around the entire area in question, we end up with a, with a so-called language map as a result of positive and negative areas. Methods how to arrive at such a map could be the intraoperative, the very invasive procedure of direct electrical stimulation. This requires a patient that is willing to do an awake surgery. So the patient is put on the operation table, their brain is exposed, then the patient is woken up, and then we perform tasks with them. And the stimulation lasts for about 4 seconds, where we can disrupt and thereby interrogate the brain. On the other hand, there is the non-invasive TMS form of stimulation mapping, so navigated transcranial magnetic stimulation. This is non-invasive. We can do it on anybody, on healthy people as well. The difference is we have an electromagnetic stimulation here. The assumption and the disruption are very similar processes, but we're not requiring an open brain, so it's non-invasive, and the stimulation lasts for a shorter time of 1 to 2 seconds. It allows us, however, to do this on anybody and pinpointing very precisely on screen with help of an MRI. We can see on screen which part of the brain we're targeting. These maps used through these techniques are used as follows. The resulting intraoperative maps, so the invasive ones, are usually the last decision-making point to then execute a resection. But they can only be done in a subgroup of patients due to its very invasive nature. Hence, for the majority or all the other patients, they can profit from the preoperative NTMS maps. These are in quite a handful of clinics already, standard part of the clinical workflow of imaging, diagnostics, and planning. Because the more we know preoperatively about the lesion and its relation to the functional network, the more targeted the patient consultation can be, and especially the more targeted the surgical planning and execution can be. So the more we know, the more targeted the craniotomy, so the access to the brain can be, the shorter the surgery is, and on top of that, it increases the confidence of the surgeon. Now, this is what stimulation mapping looks like in its different forms. We're mostly here today, however, to talk about the language tests during this. All of this started back in the 1950s with Penfield and colleagues that worked first with the intraoperative mapping, so the DES mapping. And before the medical and linguistic field joined forces to come up with tests for this scenario, the clinicians already asked themselves what task to best use to trigger and then disrupt language and then have a resulting language map. And the first instances were that the clinicians asked the patients to count from 1 to 10, or for instance, to recite weekdays or months of the year. And while, of course, this is a great first idea to trigger output that then can be disrupted by the stimulation, these tasks only trigger so-called automatic speech. So this is not language, this is just a very rudimental part of speech that probably you could do when somebody wakes you up in the middle of the night. So you're not necessarily producing meaningful language, but just automated speech. On top of that, we're in the search of good tasks for DES and for language mapping overall, we need to keep in mind the restrictions in the OR. So we need a task that is both meaningful, but it also fits the small time window of about 4 seconds, and preferably is a production task, because that would be easiest to judge. Since you have output, and if there's no output, then you can assume there's an error. Nowadays, luckily, we do have entire protocols for DES mapping, and they usually entail object naming, the most common task, and we'll come to that in a second. But overall, they're tasks spanning over all kinds of linguistic subskills. So for the pronunciation, so the sound part of language, the semantics, the meaning part, the grammar, the syntax part, and so on. And they exist, there's full batteries, for instance, for Russian, Dutch, Portuguese, English, Spanish, and Italian that are free to use. However, as a second question, I was wondering if you have any idea what might happen if we just import tasks to TMS, so the much shorter time frame from DES or any other clinical setting. Do you think there's no issue at all with that, since these seem to be valid existing tests? Might it be that the tasks are too complex, and therefore we have a discovery of many false positives that are not real language areas? The task could be too complex, and therefore we see no errors at all, or maybe a combination of B and C. I'm quite curious about this. I don't usually have talks where I can ask the audience things, so I'm looking forward to replies for this, and I will clarify the answers.
So, Ani, around 70% of the participants have already voted, so I just close the poll and share the results. Can you see the results?
Yes.
Okay, perfect.
So a handful of you have suggested there are no issues with that. Some of you said that the task might be too complex, or B and C, which the majority of you answered, and that is fully correct. Both answer B and answer D, which incorporates B and C, might be correct. So yeah, you were perfectly correct in saying due to this shorter time frame, we cannot simply take the DES tasks. We need tailored TMS tasks. If we have way too long tasks, they cannot finish them, then it looks like they made an error, but it's not actually an error. So that would be, highly wrong to assume that we have found language like that. So it does need tailored TMS tasks, and a tailored object naming just for TMS does exist, and we're going to have a closer look at that one now. Here's what most of these stimuli, regardless of which system or which corpus you use, look like. It's a black and white drawing with, here in German it says das ist, in English that would be that is, a lead-in phrase. Object naming is known as the best short task to trigger language production. It's the go-to task for most setups, as I mentioned, often with this lead-in phrase. And what this lead-in phrase does is it triggers a noun and article as well in a sentence context. So you have a bit of grammar that is being triggered here. Now, in order to be able to name such a picture, there's lots of neurocognitive processes that have to, be executed to work. So apart from visual processes, so just visually be able to see the picture, we have the following steps. I'll walk you through the table. So first of all, we need to kind of retrieve the concept. So the concept of a chair, that it's an object to sit on with 4 legs, one person fits. And in the next step, we need to find the appropriate label for it. The label, in this case, a chair, needs to be retrieved from the lexicon. So this is called the lexicosemantic word retrieval processes, step 2. Once we have that label, so what it actually, in letters, it's most easy to imagine in letters. Once we have that, we need to put it in a sentence. We need maybe this, a form of to be. Is it 1 chair? Is it 2 chairs? This is called morphosyntactic or grammatical encoding. And as a last step, we need to find the right sounds to go with our word. So this is phonological encoding, and to articulate it. So to have the right muscle movements to actually produce this. All of these processes have to work for us to be able to name the picture. Especially now in combination with the lead-in phrase, we can now use object naming and stimulation, and it helps us pinpoint to look for the breakdown of where language is disrupted by the stimulation based on which error type we see. So, for instance, if the patient or participant is not able to name anything, so we're stimulating and no speech or language whatsoever comes out, we are classifying that as possibly an error already at the conceptual retrieval level, or non-linguistic error. Whereas if, for instance, he or she says, this is a bed, even though they're seeing a chair, or they're only seeing this is, but they cannot retrieve the label, then this is called, for instance, a semantic paraphasia, an anomia, all of these being retrieval errors, lexicosemantic word retrieval errors, so in the second step. If an error such as this is chairs comes out, then this is a grammatical error and helps us pinpoint that the grammatical encoding must have been disrupted by the stimulation. Or, for instance, if they retrieve the wrong sound and they say something like this is a tear or this is a chair, so something with the muscles not working, then phonological encoding and articulation have been disrupted. As a next question, to keep this interactive, I brought another type of error. So the patient or participant sees the following picture of a newspaper, but answers while being stimulated with, this is a book. Is this now a articulation error, a grammatical error, a retrieval error, or a less definable non-linguistic error? This is the next poll.
All right, around 70% have voted, so let's close the poll and see what the results look like.
Yeah, I see that a couple of people have answered for A, B, or D, but the majority, so 2/3, have correctly said that it is a retrieval error. That is correct. Since we were hoping for the label correctly to be retrieved, that this is a newspaper, that instead the wrong label was retrieved, so this is a semantic error. So C would have been correct. To be able to do all of this, so to know which levels are used and to be able to tell if an error happens or not, we actually need a very solid stimulus list. That means that all of our stimuli have to work in our TMS timeframe and are hopefully pre-tested. So we're not just taking random pictures, but they are from a test battery that we trust, so that we know that they elicit the desired answers. And this is called often a high naming agreement. So showing these pictures to a lot of people will always, or at least in 90% of people, elicit the word chair and not sofa, etc. So this establishes a good item list. And on top of that, for all your items that you have, you can collect additional linguistic values that are known to influence naming. So for instance, how early in life was the word learned? How frequent is it? Is it a living object or not? Is it very long? And why are we doing this? It's because we could sort the list according to the patient or participant profile. So let's say a patient already suffers from aphasia and is having a hard time with long words. So we could disregard some of our items already before we do a naming under stimulation in order, again, to have a good item list and to not run into false positives due to their pre-existing deficit. Also, we could use the values, the linguistic values we know about the items and incorporate them in models if this is something you're working with to, for instance, predict outcome, etc. They just help us to define our items a bit more. Now, the talk wouldn't be called Extending the Protocol if this is all that we would be working with. So while object naming, as I just showed you with all its perks, is handy and well established, there's arguably more to language than naming nouns. So if we are extending the protocol here off to pole number 4, what do you think should be the second task to add given the short TMS timeframe? Might we want to add a spontaneous speech task where we just let the person freely talk? What could be also handy, maybe a comprehension task where we're checking another modality of language. We could add a color naming task, which is very frequent, of course, in daily life, or a verb naming task where they have to say, yeah, what action is going on, what is happening, yeah, in the picture, apart from just an object.
All right, so let's close the poll and see this interesting result. The comprehension task has the highest vote.
Yeah. That is very good to hear, and I'll come back to that in a bit. A few of you said spontaneous speech, a few said coloring task, and about a fourth of you said verb naming. So let's see how I feel about this answer. None of this is really wrong. Most of you saying comprehension is a really good candidate since it is, as I said, the second modality of language. It is just much harder to do under stimulation due to several constrictions, just such as that while you're being stimulated, there's noise from the coil, there might be a lot going on. So maybe you need to hear the input and then answer, and the answering can then not be a stimulus, but maybe just a yes or no question. So comprehension is a very good addition, but just much harder under the TMS timeframe. So from our point of view and what I worked on, or what other modalities have also found, is that the best candidate to add is possibly a verb task. We know this from other demographics, such as stroke patients or other methodologies, that verb tasks can best capture daily language skills, meaning somebody that scores rather low on a verb task, and I'll show you those in a second, it very closely correlates so how they do in overall a daily life with their language. Vice versa, if they are scoring really high on a verb task, it correlates with them having an overall really high daily language skill. On top of that, we are aware of patients that have a deficit, for instance, in a noun task, but not in a verb task, and vice versa. So it seems to be that the brain uses segregated neural areas to take out the two tasks. Hence, we can conclude that verb knowledge, verb task proficiency is a crucial part of language production. It's beneficial to preserve since it's possibly double dissociated from nouns. So preserving one, mapping one, and thereby not harming one does not entail not harming the other one. So we best include both. This was the goal of my PhD project a couple of years ago and beyond, to deepen the TMS setup with this new task that is incorporating the second big word class of verbs that can trigger grammatical encoding on the verb a bit more. I'll show you in a second. And that also triggers those retrieval processes more. Here's a typical action naming stimulus. Again, a simple black and white drawing. With a lead-in phrase, it's similarly easy to administer. Since the stimuli look similar, a short but more complex situation is triggered here. The context now doesn't just have one entity like before, the chair, but now we have a person and an action, or even a person, an action, and an object, the object of the book that is being read here. And the lead-in phrase, the man, now triggers our verb, which is here to read, in sentence context, and thereby also requires grammatical encoding. So the man reads, not just the infinitive, but a small sentence is triggered. Once more, we need to run through several neurocognitive skills in order to execute it fully. The table is the same as before. Now, for the example of action naming, the man reads the book. Once more, the concept has to be retrieved. So now our action, our verb, is an action of translating letters into words. We need an object to decipher, made of pages, etc. Then we're looking for the labels matching this. So man, read, book. In the next step, we then insert all of this into a sentence. So is this one man or two men? Is it reading, read, will have read, reads? Is it one or several books? And lastly, again, we have to find the sounds matching our labels and to produce them. But now, compared to object naming, we have a more difficult task to do during retrieval. So step 2 and 3 require more cognitive effort, since more information has to be retrieved, more roles have to be assigned that the verb takes, and more encoding happens. As you see in all the options to choose here, who is actually doing this and when. Similarly to object naming, also the errors we can see under stimulation can now give us insight to which level of production is disrupted. So once more, we could have, when we're showing this picture up there, no output whatsoever. So concept retrieval, non-linguistic error might show up. We might have an output such as the man sleeps, which is the wrong label. So we have a lexicosemantic word retrieval error. The encoding could have gone wrong, as in the man reads, or the phonological encoding. So the wrong sounds are either selected or mispronounced, as in the man teats, for instance, or the man reads. So a bit of a prolonged sound here. To stress the complexity of the increased complexity of action naming even more, we have many more linguistic factors that are known to influence verb retrieval and to make it a slightly more difficult task. So we have just as before, when was the word learned? How frequent is it? How long is it? But also how regular is it? Is it one or more people taking out this action? How many exactly? Is the verb maybe related to a noun? For instance, to hammer with a hammer is noun relatedness, or that you are writing with a pen. So all of these things might make it even harder to produce verbs, and we might want to incorporate all those values. And that's exactly what we did in the test battery that I produced, that me and my co-authors produced during my PhD project. It's called the VAN-POP, so verb and noun test for peri-operative testing. And it entails precisely object and action naming in sentence context for 3 languages, German, Dutch, and English. Here are 2 more examples. This is a frog, this is a sleigh, the man pushes, the woman sits. And most importantly, we made sure that they're suitable for DES and TMS parameters. How did we do that? We ran through several steps of so-called standardization, because we wanted really the ideal pictures to elicit the production targets we wanted. So starting from a lot of drawings, around 300 objects, around 160 actions, we did a pre-selection ourselves for targets that we deemed useful. Then we showed this pre-selection to 10 native speakers per language to see if it overall elicits the right words. So if it really, in a lot of people, ends up being called a chair. And then in a bigger validation step, we asked yet again another 30 people under the strict time constraints of TMS and DES, so the 2-second window, 1 to 2 second window, if they can still name it under pressure. And only the ideal items that made it under those conditions to reliably be named with the target that we had hoped for made it to the last list, the final list. We also collected those crucial values that I mentioned before, and then went to put it to use. We first went to do cortical mapping, so TMS mapping in healthy participants. And we already found in the non-clinical group that our verb task, action naming, leads to more errors in healthy population, and particularly so more lexicosemantic retrieval errors. This is what it looks like on a group level. Here in orange, you can see in the ventral precentral gyrus, so the area with the 13%, particularly here, lots more errors than with the noun task and in the temporal lobe as well, which for us meant that we can conclude that action naming might be more easily disrupted by TMS, since it's more difficult, and it might be a valuable addition to the standard noun task. Often you have cases where with a noun task you have close to 0 errors, and action naming, so the verb task, could help us increase this and is therefore a valuable addition. Secondly, we employed it for subcortical white matter tracking. I'm not going to go into detail about this method, but you can use the TMS points to visualize the white matter connection tracks, and action naming leads to a better visualization of the subcortex, particularly the ventral stream. For those of you who this means, who might be working with the subcortex. So we have here one participant case where you can see for object naming, the network it visualizes is much smaller and less detailed than the one for action naming, and the ventral stream, that is the turquoise and the yellow streams of white matter tracks here, come out much better with the action naming task. Therefore, once more useful in displaying the overall network. Lastly, and most importantly, because this is the demographic that we were aiming these tasks for, we applied the mapping with both tasks in 21 clinical cases with different lesion sites and types, so all kinds of different brain tumors. The 2 tasks were used in both a pre-operative TMS and DES mapping in the clinical workflow of imaging, pre-operative diagnostics, then the intraoperative verification of our TMS results, and also post-operative evaluation of how well the patient is doing after the operation. And I've brought 2 cases to illustrate how that looks like. The first case is a insular high-grade glioma. This is a very aggressive and fast-growing tumor in a young gentleman who had no deficits before surgery when we tested him on various language skills. During TMS mapping, maybe you can eyeball yourself here, we found a bigger network on the cortex, so more areas during action naming here on the right than for object naming. Similarly, for the visualization of the network underneath, we can see here it's both bigger and also it comes closer to our insular lesion. So here the big lump you can see in brown. So the yellow tract comes close to it. In the OR, so the intraoperative verification of those points, it turned out that action naming with TMS was better at predicting what we saw in the OR. So our DES mapping, the invasive one, confirmed our action naming TMS points, in particular the one in the temporal lobe. And here you see 2 images of the cavity, so where the tumor had been taken out and how close the network gets to it. So anatomically, we saw postoperatively that the lesion, so here the resection, might have damaged the action naming network. You see it here, how close the yellow track comes to the red hole. And that is in line with how this patient was doing behaviorally, because his object naming remained normal. He could still name all of the objects close to perfectly, just like before, whereas action naming, so naming the verbs, dropped dramatically after the surgery. So we can see here that visually, what we're seeing visually for the anatomy also holds for the behavior. Another case is this slightly older gentleman who had a re-resection on a less aggressive tumor in his inferior temporal gyrus. He had very mild deficits before the surgery, and here's what happened under TMS. Once more, on the cortex, the TMS maps for the verb task action naming is much bigger, so more areas came out. On the subcortex, however, and here you see a very small tumor in brown towards the bottom of the image. We see here that the white matter, so the connection network, comes actually closer to the object naming. Sorry, our network of object naming comes closer to the lesion than for action naming. Again, here the yellow track. In the OR, intraoperative mapping once more confirmed what TMS with the verb task action naming predicted. So it seems that action naming is a bit of a better predictor of what happens in the OR. And here's where the cavity is, so the hole where the tumor had been in red. And anatomically, you could hopefully already see in 6G that the lesion possibly damaged the object naming network. Whereas it stayed further away from the lesion in 6H. Therefore, my last poll question is what outcome you expect for this case number 2. Do you think there might be immediate improvement in both tasks and the person got even better? Do you think there's a drop only in object naming, only in action naming, or maybe in both?
The last poll is ongoing, Annie.
Thank you.
All right, I will close the poll, and it seems there is some level of disagreement. Can you see the results now?
Yes. So it seems to be that nearly half of you said there's a drop in both. A few said a drop in only action naming, only 20% said in object naming, and a third thought there might be even an improvement in both tasks. This was a bit of a tricky case, I agree. Indeed, we saw behaviorally a drop mostly in object naming. So this is in line with the anatomy. So the anatomy of object naming was damaged, and therefore the skill also goes down. However, and this you couldn't have known, is there was also a slight drop in action naming. So basically also in both tasks, but it was not a significant drop, but we saw it for those verbs that use an object. So the ones I mentioned before. So it might be writing with a pen and sawing with a saw, etc. So we can conclude from this that it seems that the object retrieval, so something to do with the object, was still damaged. So overall, the verbs are fine, but those requiring an object still are giving this patient a hard time. Very interesting case indeed. And here's what we can conclude from all of this. I hope that I could show you that the combination of NTMS and white matter tracking can capture the language network and also the damage to it. But in order to be able to see all this, we need a good task with valid stimuli that let us tailor both to the location and the status of the patient, and that also allow us to look for those very specific errors we talked about. And overall, not one task fits all. So those two opposite cases I just showed you, where the drop was in one task or the other, and really based on the location, we couldn't have guessed right away which to use, but only after mapping. We just need to assume overall that object and action naming recruit at least partially different networks. So preservation of just one, mapping with one, having these results, using them in the OR, and then being able to preserve just one does not entail the preservation of also the other. So therefore, if possible, if time allows, we recommend to map with both tasks. Particularly, we recommend care for cases that have a lesion in the temporal parietal occipital junction, which is an area that's very densely packed with a lot of language areas and tracks underneath, so white matter network connections. And for us, it showed that TMS mapping with action naming, so the extended task, is particularly helpful in the superior temporal lobe. This is an area that is known to do this label retrieval, so the lexical semantic retrieval. So we want to be sure that we know which areas here are crucial in the individual, so that we can delineate and then preserve them. Lastly, as a little outlook, of course, all of this would benefit from bigger group studies about to be published next year that can investigate a bit more the benefit of one task over the other and maybe help us even form suggestions for which task to use where. But once more, the final decision should always be made on individual basis, and if you can, use both tasks. On top of that, we're looking into adding further tasks to the TMS setup. So some of you correctly answered that it would profit from a comprehension task, and we've been working hard on that. It's in preparation. It is much harder to achieve, much more restricting conditions, but we're working on that. And also, for instance, a repetition task might be helpful. So this is something phasic patients struggle with a lot. And lastly, the VANPOB does exist already and is standardized in German, Dutch, English, and the English in New Zealand, but we're always looking for adaptations to new languages. And in preparation, for instance, are Afrikaans and Swedish. But this goes out to everybody who's interested. We're always happy to assist in the steps of standardizing this to yet another language. It usually needs a dedicated person of the goal language to supervise the data collection and run through those standardization steps. But we're very happy to assist with that and to have even more languages available. And maybe as a transition to the more practical part that we're going to see from the A&T team now, I wanted to mention that in order to be able to use these tests, object action naming, whichever it might be, you only need files with those solid stimuli in JPEG or PNG format that are easy to upload to most systems of TMS. So that makes it easy for us as a user. On top of that, ethically, most commonly just replacing or adding picture stimuli falls under the same ethics that might already be in place for your current situation. So also this wouldn't hinder adding a new task. It just to be aware, sometimes we need to work with longer presentation times per individual when we're adding these new tasks. But if you have any questions about that, or in general, or you would like to standardize it in a new language, have any questions or recommendations, feel free to reach out. Here's my my email address, but also A&T is very welcome to hand out my contact information. That's it from my side.